And dear PGT, now we are going to resume our monthly, actually it is twice monthly master class on behalf of the ICP forum, which is the academic wing of API West Bengal branch. Now I request Dr. Anand Bagchi, who is the chairman of API West Bengal branch, to introduce today's chairperson, and if he likes to say something regarding our master class. Anand Bagchi, please.
Thank you, Amalda. Good morning, everybody. Thank you, Professor R.N. Sarkar and Dr. Sapan Pandya, today's speaker. Dr. R.N. Sarkar is a senior physician, consultant physician and rheumatologist, and he was the ex-head of the Department of Medicine and Rheumatology, Medical College, Kolkata, and he was ex-chairman of API West Bengal chapter. Today, he will chair the session, and with these few words, today we have got speaker, Dr. Sapan Pandya, who will talk on rheumatological pattern recognition in rheumatology practice. As you all know, the rheumatological diseases are increasing day by day, and diagnosis is also being done with very effectively. So we must know the total rheumatological disorders in our day-to-day practice. Without wasting much time, I will hand over the mic to Professor R.N. Sarkar for continuation of the lecture.
Good morning, everybody. Dr. Amol Banerjee, our President, Chairman, Anand Bagchi, and all the postgraduates and my fellow colleagues. Today we have a very interesting topic, which will be dealt by Dr. Sapan Pandya. He is a rheumatologist of national fame in a very young age, and he was a past secretary of Indian Rheumatology Association. He has done his postdoctoral DM in clinical immunology and rheumatology from SGPGI Lucknow. He has multiple publications in national and international journals, and was very important publications were methotrexate and hydroxychloroquine chick virus arthritis, that is chikungunya arthritis, and also methotrexate twice weekly versus once weekly in rheumatoid arthritis. He is at present attached to Vedanta Institute of Medical Sciences and also assistant professor of Department of Rheumatology and Medicine at NHL Medical College and Hospital, Ahmedabad. He will be dealing with the pattern recognition in rheumatology practice. This rheumatology patients, they come as a, in the beginning, they may act as a undifferentiated. So we call it undifferentiated connective tissue disease. But as time follows, they evolve into different varieties. So it is very important to know the pattern recognition. Sapan will deal with some cases of important, how to work up knowing the pattern of the disease. Now, I will ask Sapan to please start.
Thank you, sir. Am I audible?
Yes, yes.
Yeah. Thank you very much, Professor Banerjee, Professor Bagchi, Professor Sarkar, and all other my seniors there. I take this opportunity to remember Professor Mukherjee also. My regards to him, Sukumar Mukherjee, Alakindu Ghosh, who has been more of my colleague for the last 2-3 years when I was the secretary and he was the president. And all the seniors, Professor Ganguly, Professor Dhar, and Haidar, and all my colleagues, Abro, Argo, and all the juniors, Devanjali, Rashmi, and all. Bengal has been, the first time I came to Bengal was long back in IRECON, the first IRECON, and then after that, the second IRECON was 2013, I think Professor Alakindu did. And And then after that, in the last 3-4 years, being the secretary of the IRA and Alakinduda being the president, I came almost 5 times and I fell in love with Kolkata, the city. So it seems like I'm there only and talking to all of you. And I can't do without Bengali music, Panchamda being my favorite and so many of the others. So with that background, I think I'll go on into, I usually don't talk more than 25-30 minutes because I feel that is the time span that males can have attention span only for 20-25 minutes. Beyond that, it becomes very difficult for men.
Yeah.
Women to sun leti hai, lekin men ko. But anyway, sir asked me to speak, so I have about 40-45 slides in which I've tried to make it case based so that it becomes interesting for everyone. Thanks to the input by Professor Shorkar. So I'll go on to my talk and my first slide. This is the outline of my talk, the rheumatology spectrum which we cover and what I will be covering, because it is simply not possible to cover everything even though I have enough time. I'll be speaking more about arthritides with case vignettes and be trying to cover the differentials of rheumatoid arthritis, spondyloarthritis, especially psoriatic arthritis also included in that, and crystal arthritis, which is mainly gout, maybe a couple of things about the other crystal arthritides. Then the connective tissue disease spectrum with case vignettes, lupus, scleroderma, the inflammatory myositis group, Sjogren's, mixed connective tissue disease, UCTD. What are these terms? Because often the postgraduates are, it's difficult for them to follow these terms. Vasculitides with case vignettes, small, medium, and large vessel. And finally, the takeaways, which is going to be more for postgraduates. Again, I was told that there's going to be a mix of crowd of practitioners as well as postgraduates, but the takeaways will be mainly for postgraduates. I'm sure that the practitioners already know, have their own world of wisdom, which they can use in diagnosing these cases. So with this background, I think and importantly, I'll be focusing more on the clinical characteristics and maybe a little bit about investigational interpretation, but not really into investigation and treatment, because that is not something which is going to be covered in this talk. So with that background, let me move on to my first slide. So this is a spectrum of diseases that rheumatologists see. You have the arthritides, the connective tissue diseases, the vasculitides, and then we also have now organ-limited autoimmune diseases and some miscellaneous diseases. The arthritides, as you see, would be inflammatory and non-inflammatory. Above are the inflammatory arthritis, rheumatoid and spondylo, and then the non-inflammatory ones like osteo and crystal, of course, can be inflammatory, is usually inflammatory in the acute stage. And then connective tissue diseases, this is a list of the CTDs that we usually deal with, the vasculitides, and then there are these new organ-limited diseases. And since this slide is a little old, if you see the first, if I can point out, and I'm not sure if, are you able to see when I point this here?
Yes,
Yeah, so that's the lung dominant, used to be called the lung dominant CTD. And if you go a little back to the history of this particular disease, what happened was, and all of you, I'm sure, as rheumatologists and as physicians, we used to get these referrals for interstitial lung diseases which had ANA positivity. And 10, 12, 15 years back, when I did my DM and I came back, I used to tell the pulmonologists कि ये हमारा केस नहीं है, मतलब इसमें ANA false positive है, इसमें कुछ करना नहीं है, you deal with the ILD. The patient doesn't have any other features to suggest any other connective tissue disease. Slowly, what happened is people realized by having collected data that these patients ought to be treated as in our diseases, which means that if you have an ANA strongly positivity and an ILD, then you would rather treat it as scleroderma ILD or rather than just idiopathic ILD. So that was the difference, that these patients responded better perhaps to immunosuppression than the idiopathic ILD. So that's how lung dominant CTD came to be known as IPAF, interstitial pneumonitis with autoimmune features. And there are criteria to these. I am not be going into the criteria of any diseases because these are mainly classification criteria. And it's important to know that when you are on a bedside, you really don't need the classification criteria. The classification criteria for the postgraduates, I'm sure they know, are for including patients into clinical trials. They are not really for a bedside diagnosis. You don't need to fit everything into a bedside diagnosis. So you still have to treat the disease. So that's called IPAF. Similarly, there are other dominant disease on stool. I believe we'll have a spectrum of these like CNS dominant CTDs and in the future, which have predominantly only one organ involvement. And then there are miscellaneous ones like sarcoidosis, fibromyalgia, IgG4, And the latest of these is, of course, the Vexus syndrome, which I'm sure all of you must have seen in the New England Journal of Medicine last December. So the spectrum keeps on increasing, especially what are called the auto-inflammatory syndromes. Now, the difference between auto-inflammatory versus autoimmune diseases is that for the definition of an autoimmune disease, you need either an antibody or evidence of a T cell response to the antigen. When you have predominantly the innate immune system which is causing the problems, these are called auto-inflammatory syndromes. And many of the autoimmune diseases, which we thought were autoimmune disease, now started included in auto-inflammatory syndromes, examples being Crohn's disease or even sarcoidosis or gout. So these are increasingly being classified into auto-inflammatory disease. As immunologists, we believe that it is probably a continuum. All the diseases have an innate immune response to begin with, and then they go on into autoimmune diseases with the adaptive immune response. But in children and in young adulthood, you find only autoinflammatory syndrome, which are just innate immune system problems. And many of these are now being diagnosed. The list of autoinflammatory syndromes is increasing every day. I will not be covering that because that becomes an entirely different topic and is predominantly dealt with by pediatric rheumatologists. So that is what I'm going to cover. I'll also try and cover rheumatology mimics, and all of us know that the mimics that we are scared of when we are diagnosing connective tissue disease and systemic autoimmune disease are leprosy, tuberculosis still being the most common in our country, fungal infections. All of us have been stumped with an occasional mucormycosis, subacterial bacterial endocarditis, syphilis, and now of course COVID-19 is also there. And then we have inflammatory syndromes like sarcoid, APLA, atherosclerosis, IgG4, and paraneoplastic lymphomas like the lymphomatous granulomatosis or NK cell lymphomas, which mimic midline granulomas, earlier they were called. They mimic Wegener's granulomatosis. And miscellaneous diseases like hypermobile joints, endocrinopathies like osteomalacia, diabetes. So these are things which you have to keep in mind when when the patients come to us, and we have to weigh the symptoms and signs and rule these out or follow up patients sometimes sometimes they're eventually diagnosed as other infections or something else. This is a photograph from New England Journal of Medicine showing amyloid, which is a great mimic of our problems. These are small amyloid deposits on the skin. And the lower one is a mycotic aneurysm, which was reported again in one of the New England Journal of Medicine images. So these are things that you have to keep in mind. Sometimes only a biopsy tells you what these problems are. So going on to the first group of diseases, the arthritides. Uh, uh, just one slide on what the meaning of these. So all of you know perhaps this for postgraduates and the first year postgraduates actually. Inflammation in our language means early morning stiffness. So if you have early morning stiffness more than 45 minutes to an hour, then that becomes significant inflammation. Because with increasing age, you might find morning stiffness for about 15 minutes or 30 minutes. That's fairly normal. So beyond that becomes clinically significant. Arthralgias versus arthritis. Arthralgias are just joint pains, whereas arthritis are joint pains and swelling. The duration of illness is extremely important, and that is something that I tell my postgraduates when they come to me for rounds. I think two things that I need is that what is the age of the patient and what is the duration of illness. It gives you a perspective, because if you have a patient who is 10 years down the line, you start thinking in terms of damage कि इसको atherosclerosis भी होगा, इसको शायद coronary artery disease भी शुरू हो गया होगा, especially if the patient has comorbidities. Even uncontrolled or even controlled inflammation has to have some damage. So that's how we see it. And that's why duration of illness becomes extremely important. Also, it becomes important because if you have a short history, for example, a week's history or 2 weeks history, then you still think of infections and not inflammatory diseases, unless there are some very hardcore signs or investigation which support. Otherwise, you think of infections. So duration of illness is extremely important. Periarthritis, whether it's an arthritis or whether it's around the joints, that becomes important. Whether it's an enthesitis. Now, for postgraduates, enthesitis is where the tendons and ligaments bind to the bone. These are sites like Achilles, Achilles tendoachelis, the plantar fascia, the tibial tuberosity, the anterior superior iliac spine, and sometimes in the ribs also. These are enthesial sites. Dactylitis is when a single toe or a digit is swollen, which is also called sausage digit. And it's one of the favorite MCQs for postgraduates of medicine as well as rheumatology. What are the causes of dactylitis? Tendinitis, very important again, whether it's a tendinitis or arthritis, whether there is entrapment neuropathy, which is carpal tunnel and tarsal tunnel syndromes, whether there is fasciitis, and very importantly, paniculitis. Now, paniculitis is something which is often labeled as cellulitis by physicians and orthopedics, and it is very important to know that by and large, infections are not bilateral. It is not always a rule. You can have, especially in an immunocompromised, but if you have bilateral on the legs, inflammation which is on the in the skin and the underlying fascia, it is more likely to be paniculitis. Think about paniculitis, especially in the correct context. When the patient has received antibiotics and has still not respond and those kind of things, and then you start thinking of paniculitis. So only a biopsy tells you whether it's a paniculitis, but think of paniculitis, and I'll come to a couple of photographs which will probably show you what paniculitis looks like. Now let's come to the first case. So this is a 52-year-old lady who presents with 6 months of illness. She has moving aches and pains. The pains last for a day or two. There is redness and there is very severe pain. If you can look at the photograph, this is the red kind of redness these patients say. Very often this is more of a periarthritis than actually the joint, around the joint. And the patient, when they come to you, there are no deformities, no restriction of movement. The ESR is okay. Somebody is on an ASO which is raised, and the RF is mild positive, but the anti-CCP antibody, somebody's done that as well, is strongly positive. The X-rays, of course, show no erosion. So what's the diagnosis here? Now, this is an entity which I had seen during my DM days, but I really picked it up after coming into practice and started, because when some of these were young girls, when they came to me, they really didn't have anything to suggest inflammation. It was just there in the history. So I missed. And I started calling them false positive CCCPs or CCPs to be monitored to evolve into rheumatoid arthritis. And then I started realizing when I asked them, they said, and you have to really go into the details of asking them, कि सर इतना पेन होता है कि मैं वो जॉइंट हिला भी नहीं सकती हूँ 2 दिन तक. Now, this is something that patients will not feign about if there is very severe pain. And you know some patients will not feign. So if there is that much of pain, there is something there. And then I started asking them to image, to photograph those in the world of mobile phones and send to me. And this was the kind of images they should send to me. So when the patient comes to me, she doesn't have anything. But once a week, once in 2 weeks, she gets these kind of attacks. So this is what we call palindromic rheumatism. And many people believe that palindromic rheumatism is an early form of rheumatoid arthritis, and that eventually such patients, especially who are seropositive for CCP antibody, will evolve into rheumatoid arthritis. It is important to know that palindromic rheumatism sometimes stays as palindromic rheumatism. I have seen patients, and I have a subset of patients who remain palindromic for years together. They don't have damage in the joints, but they have very severe pains, which for that particular day limits them in terms of their function. But otherwise they are fairly okay. And some of them do evolve into vasculitides also. And I have at least a couple of patients who have evolved into, one patient into an MPA, microscopic polyangiitis, and ANCA-associated vasculitis. So this is not to say that you do ANCA in these patients, but you keep looking at other symptoms and signs in these patients. So this is called palindromic rheumatism. And they don't have any damage. So if it is not very frequent, you may just treat them NSAIDs, but otherwise they may need treatment like rheumatoid arthritis. The second case is a 52-year-old lady who comes with 2 years illness again. So this is still early. Symmetrical inflammatory additive pattern of involvement. Additive means that there is already one joint involved, and on top of that you get another joint. Small and large joints, hands and wrists, restriction of movement of both the wrists, which suggests some kind of damage in the wrist joints. The ESR is fairly high, but she is seronegative for rheumatoid arthritis. The X-rays show joint space narrowing. JSN stands for joint space narrowing. There are few erosions in the MCP joints. Now, what is the diagnosis? This is the kind of picture these patients have. The kind of look at the PIP joints are all inflamed. Now, I purposely written here is there is a subset of rheumatoid which can be seronegative. Not all of them. We know that rheumatoid factor is about 70% sensitivity as against the same level of specificity. On the other hand, the CCP antibody is a very specific test, which means if you are CCP positive, you are very likely to be rheumatoid arthritis, but the sensitivity of anti-CCP antibody is about 55% in various series. So you may miss rheumatoid arthritis if you do. So there can be a subset which can be, I understand that if you have rheumatoid factor and CCP both, you virtually diagnose all the rheumatoid, but there is a 10-20% you can still miss by these two investigations. So this is just to say that one has to go clinically when you see these patients, and especially for postgraduates, that constant focus on the clinical history of the patient in examination. The differential here would of course be chikungunya arthritis in our part of the country, where chikungunya is now sort of endemic and you have every year these cases. I'm sure it must be there in that part of the country as well. And so these are some patients who keep getting the arthritis every year. You can have a differential of some of these can evolve into connective tissue disease spectrum. So you have to keep a watch on them for the symptoms and signs of CTDs. But this is seronegative rheumatoid arthritis. Coming to the third case is a 72-year-old gentleman who had been a heavy smoker. And I purposely write here a smoker because smoking is known to be a risk factor for rheumatoid arthritis, both active and passive, especially CCP antibody positive rheumatoid arthritis. Smoking has also been found to be involved in the pathogenesis of ankylosing spondylitis. Now, there is evidence for both of these diseases. This gentleman has 15 years duration of illness. He has a deforming arthritis of hands and
Sapan,
feet. Yes, sir.
lady, not
Yeah,
gentleman.
the photograph is a lady. That's a different. This is just to show the nodules. The gentleman was
fine.
different. This
Okay,
is just so deforming arthritis of the hands and feet. Also, not much early morning stiffness now. The ESR is okay. Rheumatoid factor is positive. The CCP was not done because 15 years back we were not really doing CCPs, and it doesn't make any difference to do a CCP now for this patient. The X-ray shows marked destruction of copper moles and erosions. Now the question here is, what will you look for in these patients? So here, this is a different lady, of course, but this is just to show that subcutaneous nodules can be there in these patients, and they suggest an aggressive disease. And most of these are circulating rheumatoid factor deposits in the nodules. So most of these patients are seropositive. But the important thing to note here is that rheumatoid arthritis is diagnosis already ho gaya hai, and he has now received multiple treatment in the past and gone beyond that, what we used to call burnt out rheumatoid arthritis. Many people believe that there is nothing like burnout and that there is still some smoldering activity which goes on. But important thing here is that in these patients, and these are increasingly uncommon now, we look for what is called as the extra articular manifestations of rheumatoid arthritis. And what are these? One of them is of course shown here, subcutaneous nodules. So these could be interstitial lung disease in the first photograph, which can precede rheumatoid arthritis. We cannot exactly call an extra-articular complication. It can be a part of the disease, but uncontrolled disease, people have shown, can go on to have ILDs. And then this is gangrene, which is a medium vessel vasculitis, can happen in rheumatoid arthritis, especially those who are rheumatoid factor positive. That's a non-healing ulcer, which could be a pyridoma gangrenosum, or it could be a rheumatoid vasculitic ulcer. You can see here the punched out ulcer below. So you do a biopsy from the ulcer edge of this patient and you find fibrinoid necrosis, which will confirm rheumatoid vasculitis. Some of these patients can also get what we see here is a keratitis, is a peripheral ulcerative keratitis, a PUK, which can be a complication of rheumatoid arthritis. It is equivalent to a corneal vasculitis, and these patients can harbor vasculitis elsewhere in the body as well. So that's important to know. And some of them can have corneal melt, which is a medical emergency. The cornea suddenly starts melting and you have to treat them very aggressively. Important to know is that the message here is that when the patient is 15 years down the course of time, you start looking for the extra-articular manifestations, especially if the patient has not been treated appropriately. Increasingly, we are finding this uncommonly now. And I remember when I did my DM, the international speakers used to come and see because they had not seen these patients, and which is true for us now as well. मैंने जितने DM के टाइम में ये patients देखे थे, I'm really not seeing these complications now so commonly. So we are treating rheumatoid fairly well, but you have to be aware of these when patients come with long-standing rheumatoid arthritis. What are the mimics of rheumatoid arthritis? Fibromyalgia is the closest mimic because many of these patients, women, complain of aches and pains. There is no real swelling, and you're confused. So that is something a diagnosis with exclusion, but you keep in mind many of these patients have irritable bowel syndrome, sleep problems, migraine, and anxiety, depression, and those kind of things. Hypermobile joints below is again young women coming with aches and pains. There is a triad of hypermobile joints, fibromyalgia, irritable bowel syndrome. So again, they can have those kind of pains. In the middle picture is, if you can see the DIP joints here, there should be nodules there, and also the PIP joints. Now this is osteoarthritis of the DIP and the PIP joints, what are called as the Hebriden's nodes in the DIP and the Bouchard's nodes in the PIP joints. You also have first MCP in most of these patients. So this is nodular osteoarthritis. This is not rheumatoid arthritis. Very often orthopedics do label them as rheumatoid, especially if the rheumatoid factor is mildly positive. Remember, rheumatoid factor can be positive with increasing age. So it's a clinical history which is going to be most important. They don't have early morning stiffness. They don't have signs of inflammation. They just have nodules. And this, interestingly, was a patient with Hansen's, which I had seen long back, and you can see the swollen hand and feet syndrome. I'm sure that Kolkata sees more of Hansen's than we may be seeing here. But this is, once you've seen this, you will never forget. And the moment you see these shiny fingers and this kind of a response, swollen feet, you at least ask about leprosy in these patients. So these can be the differentials for this kind of a polyarticular syndrome. There are other syndromes like RS3PE, which stands for remitting seronegative symmetrical synovitis with pitting edema, which is believed to be a distal equivalent of polymyalgia rheumatica, where you have tenosynovitis of the feet. I will not go into the details of that. You may look up on Google, postgraduates who want to look up, but that's again a differential of distal joint arthritis. Coming to the fourth case is a 26-year-old gentleman who comes with history of, he was told that he had sciatica 2-3 times in the last 2 years. And when you ask in detail, because everything is sciatica unless and proved otherwise, they tell you that they had a buttock pain on one side, which lasted for 15 days. 1 month was very severe, more at night, and improved with moving. And then alternated, but sometimes they had in the left side, then there was 6 months gap, then again on the right side, that kind of thing. Sometimes, and it was accompanied by low backache, worse at night. Left knee arthritis 6 months back, which lasted about 2 months. There's a right heel pain shown here. You can see the enthesitis here. Can you see the pointer that I'm pointing at? Is it visible? Yeah. So that's the heel. Yeah, that's the Achilles tendinitis. You can see here the inflammation. Metal uncle has psoriasis, and the CRP is high, but a B27 is negative. Now 2 points here. In the spondyloarthritis spectrum of disorders, so young male with lower limb arthritis and back pain, inflammatory and sacroiliac joints, hips, is unless and otherwise proved a spondyloarthritis. The important thing about spondyloarthritis is that the family history is extremely important in spondyloarthritis. And many a times we have picked up SPA. You see, in a garden variety case, you can always diagnose. But sometimes there are these subtle cases where बहुत clear नहीं है. The patient doesn't give a very confirmed history of backache. You can see sacroiliitis, but the X-rays are not very good. Sometimes the patient cannot afford an MRI. The CRP is plus minus. Those are the times when a family history will help you. So if the family history of a maternal uncle has psoriasis, or if the uncle accompanying the patient, sometimes they are stooped forward like that, and you ask them and they say, yeah, I've been stooped forward since many years, but I don't have any problem. Those are spondyloarthritis. So the family history is very important in SPA. The HLA-B27, that is the second point I want to make. Something I feel is overrated. All our generation rheumatologists feel that, and as I have been saying in my talks, that I probably ordered HLA-B27 about 20 times in my career, not more than that, in a span of 15 years, because I don't think it really helps in diagnosing. You may use it if you're a part of a clinical trial or a study, but otherwise I don't see it's a 1500 rupee test. Remember, ankylosing spondylitis, 90% are HLA-B27 positive, but only about 10% of HLA-B27 positive go on to have ankylosing spondylitis. So there are a lot of HLA-B27 positive normal people moving around. This patient was HLA-B27 negative. Important to say that is the X-ray sacroiliac joints, which will diagnose the condition, and not a HLA-B27 positivity or negativity. This is a spectrum of spondyloarthritis. This is a slide I took from a recent Medscape, which I found very useful. So you can have axial manifestations. Non-radiographic means you need an MRI for a diagnosis. Radiographic means on X-ray, either bilateral grade 2 or unilateral grade 3, which is ankylosing spondylitis. Reactive arthritis is usually young males with arthritis of the knees and ankles, lower limb joints, which goes away with some time following an infection usually. Undifferentiated is peripheral is when it doesn't fit into any of these. Psoriatic arthritis is a distinct entity. Most of these patients have psoriasis, but about 20% may never have psoriasis. And then there is spondyloarthritis associated with inflammatory bowel disease, which is ulcerative colitis and Crohn's and indeterminate IBD. And these are the extra articular manifestations of these patients. I showed you enthesitis. I'll be showing you dactylitis. Some of these patients have uveitis, IBD, psoriasis, and many of them uveitis can precede the joint involvement, and so can the intestinal involvement sometimes in these patients. So these are all one spectrum, and you have to ask about the family history of all of these in these patients. These are the spectrum. So the first photograph shows a DIP which is inflamed in a young male. So this is psoriatic DIP involvement. That is dactylitis. If you see the index finger, it is single digit which is swollen compared to the others. It is more often seen in the toes actually than the fingers. This is scalp psoriasis, and you really have to look for it. Sometimes the patient says no, or वो बोलते dandruff है, लेकिन when you see the silvery flocks and behind the ears also. So you have to really look for these. These are psoriatic nails, misdiagnosed as fungal infections occasionally. And then this, if you can look here, is a ulcer, which was a patient, a young male with this kind of a huge ulcer behind, and he had weight loss and uveitis and an inflammatory bowel disease. Remember, Crohn's disease can just present with anemia and weight loss and nothing else. And this patient did have anemia and weight loss. Ultimately, turned out to be Crohn's disease on colonoscopy and intestinoscopy. This is Keratoderma blennorrhegica, the hands, which can sometimes present in reactive arthritis. It exactly looks like psoriasis. I don't know what is ongoing. Yeah. Coming to ankylosing spondylitis, these are the flowing syndesmophytes of an ankylosing spondylitis. Now this here is a differential which happens in, if you can see, these are much bigger than the syndesmophytes and much thicker. This is called DISH, diffuse idiopathic skeletal hyperostosis, or Forestier's disease. Usually these patients are in the higher age group. They don't have an inflammatory backache. They complain of backache, but which is not necessarily worse at night or early morning. The sacroiliac joints are spared. This is sacroiliitis grade 4, almost sclerosis. So this was an ankylosing spondylitis. So how to differentiate between DISH and ankspond? Because sometimes in 40-45-year-olds, if they move with their necks fused, you can't make out. You do an X-ray of the sacroiliac joint and the ankylosing will show sacroiliitis. If you are confused, you may do an MRI. Here the MRI shows bone marrow edema. So that is ankylosing spondylitis. And usually some of these, there are criteria to DISH, which I won't go into, but they are diabetics and more often involved the right than the left side. So that's the osteophyte. So that's regarding DISH. And Forestier is a differential of ankylosing spondylitis. Going to the next case is a 60-year-old gentleman who presents with multiple nodules over finger joints, lateral malleoli for about 6 years. Had painful attacks of swelling and redness of the foot joints. Presently, his uric acid is okay, 7. The creatinine is raised. There is a mild seropositivity for rheumatoid factor and CCP antibody. About 2 months back, I think there was a perspective in New England Journal of Medicine where the lady rheumatologist confesses that she had diagnosed a case of polyarticular gout as rheumatoid arthritis all these years, just because her teacher had diagnosed that patient as rheumatoid arthritis. It was a very good perspective, and what it basically said was that you have to ask, not believe anyone, and ask the history yourself and do the examination yourself. And true to what she said, polyarticular gout in an advanced form sometimes does look like rheumatoid arthritis. Those of us who have dealt those cases know there is ulnar deviations because of the tophi. And look at this patient. You have seen the tophi here. While you can make out the tophi, because I'm telling you, sometimes when there is ulnar deviation and deposits here, they look like rheumatoid arthritis. So this is something you have to ask in detail the patient. कि आपको सबसे पहले कहाँ हुआ था joint, and they tell you that the first MTB joint long back, and that the maximum uric acid is something that helps, has gone up to 9, 10, 11, 12 sometimes, so that you know that. This is again tophi. You can see here the tophi in the 4th digit and in the great MTP, and sometimes you can pick up a tophus in the external ear also. So that is chronic tophaceous gout. Now the mimics of, again, these kind of spondyloarthritis could be osteomalacia. This is loser zone. They have hip involvement, shoulder involvement sometimes, and aches and pains, and alkaline phosphatase, which is raised usually, and vitamin D, which are very subnormal. So this is osteomalacia, loser joints. This is what we call Lofgren syndrome. You can look at the ankle and the foot inflammation. Some of these patients have hilar nodes, and this is acute sarcoidosis called Lofgren syndrome. Recently, a patient I saw, and I'm sorry, this is erythema nodosum, the lower one. That is paniculitis again, septal paniculitis, and some of these patients have IBD. Some are idiopathic erythema nodosum with ankle joint involvement, could be sarcoidosis. You can also see this in tuberculosis. It is important to rule out tuberculosis in our country, and that is a very rare condition which mimics rheumatoid arthritis follicular called multicentric reticulohistiocytosis. This is just for MCQ for postgraduates. If you get this kind of a pearl and string image of these nodules, some of these have DIP erosions also. They have an inflammatory arthritis mimicking rheumatoid. So this is multicentric reticulohistiocytosis. They have it on the elbows sometimes on the extensor aspect and behind. If you've seen one, then you'll know. But the eye see what the mind knows. So this is just so that you can see these. Very occasionally you will, a rheumatologist on an average entire lifespan will see just about a couple of these cases. That is a distribution of joints for the pattern recognition. So if you have on the left side, if you have both knees here, all the MTP joints, the PIP, DIP, bilateral wrist, symmetrical arthritis, this is rheumatoid arthritis. The second one, if you look, that is sacroiliitis here, and there is an asymmetrical distribution. You have the left wrist, but you don't have the right wrist. You have the right elbow, but the left elbow is not there. And you have a single digit which is swollen, like the index, what is called dactylitis. So this is psoriatic arthritis. Look at the second toe. This is psoriatic arthritis. Even if the patient doesn't have psoriasis, it will fall into psoriatic arthritis spectrum. This is the entire spine, bilateral sacroiliac, so that becomes easy, both hips and some peripheral joints. This is ankylosing spondylitis. And here you again have the spine, but the lower part, the knees, very important, the first MCP is only, and the DIPs and PIPs. So this is osteoarthritis, and the bunion over here or the osteophyte here. So this is osteoarthritis. So this is a distribution of joint that helps us. But in a given patient, you have to really ask the history and look at if there is inflammation. There can be a mix of things. So you could have a rheumatoid on a osteoarthritis. It doesn't rule out. So if you have, osteoarthritis patients can get rheumatoid also, even if it's nodular. So you have to take the history in detail and sometimes rely on investigations to help you out there. Coming to the connective tissue disease spectrum, and I hope I'm on time. Yes, I do.
Yes, no problem. You
Yes.
can take time.
So coming to the connective tissue diseases spectrum, the common features here are that they are usually women. The age group can vary, but they can begin in childhood also and go on in 60, 65 years when they are first diagnosed. Usually Sjogren's is more towards the upper limit, whereas lupus you see more often in the younger age group. Usually non-deforming arthritis. Raynaud's is an important symptom here. So if you have Raynaud's phenomenon in a female, you start thinking about the connective tissue disease spectrum. And how do you ask for Raynaud's? You ask for Raynaud's by asking the patients कि आपकी उंगलियों के तलवे सफेद या नीले पड़ जाते हैं जाड़े में या ठंडी में. That is how you ask them. You ask them if it's white or blue, not just blue. Is there any load elsewhere? Which means that is there any other systems which are involved and not just the joint? So is there anything in the CNS or the brain, in the eye, lungs, kidneys, and skin? These are often clues to diagnosis of connective tissue disease spectrum. And sometimes you just pick up a lupus looking at the urine reports. They have been 3+ protein, 4+ protein, granulocast, and nobody has given importance to that. They've been treated repeatedly as UTIs, but actually lupus with just polyarthritis or polyarthralgias. The important thing here about connective tissue disease is that it can be organ or life threatening as against most cases of rheumatoid arthritis. So rheumatoid, unless it's a UIP of the lung, will probably create problems with the lungs and mortality due to the UIP, usual intestinal pneumonitis, is by and large not a fatal disease. It's fatal in the long term, but these patients, especially lupus and scleroderma, can really be life threatening, and that is why you need to diagnose them early. The stakes are much higher here. And there are pregnancy issues, very important. In rheumatoid, we've always thought that pregnancy में rheumatoid निकल जाता है, ऐसा नहीं है. Now there is evidence to show that rheumatoid also need to control the disease before the patients become pregnant. But in lupus, for example, pregnancy can actually kill the lupus patient if it is uncontrolled. So because you can go on to have renal involvement, and that can be tough on the patient. So since these are childbearing ladies, there are issues with pregnancy. You have to diagnose them, and you also have to know to talk to them about planning their pregnancy and how to go about it. So let's come to the first lady in the connective tissue disease spectrum. Is a 26-year-old lady who presents with 6 months of illness. She has polyarthralgias, which means there is no joint swelling, largely, low fever, some weight loss, constitutional symptoms. She has some evidence of building anasarca noted over the last 1 month. And true to what we believed, the urine shows active sediments in the form of casts, and she has an ANA which is positive strongly, homogeneous 1 is to 160, but the profile is negative. Now, how do you diagnose these cases? I have purposely written here so this, if you look at the palatal ulcer here, is quite specific for lupus actually. And for postgraduates, the ANA profile can be negative in about 30 to 40% of cases where the ANA immunofluorescence is positive. This is not infrequently I get these questions कि सर ANA तो इसका positive लेकिन profile तो negative है तो आप फिर कैसे बनाओगे? Now the ANA immunofluorescence picks up a lot of antigens which are in the nucleus and the cytoplasm as well. So it's a good screening assay. It's a very sensitive test. But the profile only has some number of antigens listed, maybe X number 20, 25. So it could still be on immunofluorescence something which is not there on the blot, because the blot is quite specific, only those recombinant proteins which are being put. So that's why this can happen. And while the DSDN nucleosome again doesn't always show up on the blot, so that's why you can have an ANA positivity and a profile which is negative in up to 30% of lupus patients as well in connective tissue diseases. So that's important to know. This is alopecia, the kind of alopecia. So it is important to know that in lupus, it can be organ threatening. So we divide lupus once we diagnose lupus. And it is important again here to know that they don't have to fulfill the classification criteria. Remember, we are talking about bedside diagnosis, pattern recognition and bedside diagnosis, not fulfilling criteria. So even if you have an oral ulcer, palatal ulcer and joints and urine showing active sediments and NA positivity strongly, you think of lupus in these patients. This is alopecia. This is livedo reticularis, which can you see in APLA. And some of these patients have recurrent abortions, not all of them. Then this is a non-healing ulcer that I had in a lupus patient, a vasculitic ulcer. The biopsy showed that. And this is intestinal vasculitis. What you can see here, the classical bowel edema, which is called the concertina pattern on the sagittal section, or here the thumb printing sign. And that's a of GI vasculitis, which can sometimes be an emergency because this can perforate. And these are patients who will require high dose immunosuppression. So once you've diagnosed lupus, we normally categorize lupus into minor organ lupus and major organ lupus. So if you have hair fall, oral ulcers and joints, these are still minor because they are not life threatening. They are not minor to the patient, remember, because the patient has joint pains. But you try and tell them that this is not major because it hopefully will not be life threatening. But if it is intestines, brains, and kidneys, then that can turn out to be life-threatening, and that is why it is important to classify these into these two diseases and also organ-threatening problem. Coming to the second case is a 32-year-old lady. She presents with Raynaud's for 6 years, skin changes noted over last 2 years. She has seen some tightening of the skin, some hypopigmented spots over the forehead, in the scapular region, and she's been violently itching for some time now. There is dry cough and dyspnea over the last 6 months, and ANA shows a nucleolar pattern. You can pick up the disease here very easily. This is sclerodactyly, advanced sclerodoma, where she's also probably developed contractures, and you can probably make out some tuft osteolysis also. The terminal digits are gone. So that's called tuft osteolysis due to X-ray, and that's seen in sclerodoma. This is the salt and pepper skin. If you can faintly see the white spots, you can see these in salt and pepper skin on the forehead also sometimes, and elsewhere in the scapula and the back. These are pitted scars, signs of ischemia, vasculopathy. These are not usually vasculitis. And on their own, they don't need treatment. But if they are associated with Raynaud's, then you might need to give them calcium channel blockers and those kind of things. That is telangiectasia of the palms. And it is important to know that when you get telangiectasia, which means remodeling has started, vascular remodeling has started happening, you can also expect pulmonary hypertension in some of these patients because they will also remodel the pulmonary vasculature of these patients. And then you have interstitial lung disease that looks like a fibrotic NSIP, most commonly being the NSIP, but you can have UIP and it's important to know that scleroderma, ILD can kill these patients, and pulmonary hypertension as well, resulting both from ILD, and pulmonary hypertension without ILD also can happen in limited scleroderma more often, but also in diffuse scleroderma. So these are complications which are important in these patients, and that's why you have to treat them. Coming to the third case, so we've covered lupus, we've covered scleroderma. This is third, a 28-year-old lady, 4 months of illness. Photosensitive malar rash, you can look at the rash here. And very important to know, if you see the eyelid, such a diffuse rash, which also spares the nasolabial fold, it goes beyond that. And such a diffuse, and look at the heliotrope kind of color, which is very classically, this is dermatomyositis. The patient also have rash over the, as against lupus, which is usually limited to the malar area. It doesn't cross the nasolabial fold, and it doesn't have a purplish hue. The malar rash of lupus is normally reddish or even hyperpigmented sometimes. Rash over the knuckles, back, elbows, extensor aspect, which is called Cotron's rash, tends to fall down while walking. This is what some of my patients have told me. The muscle weakness, they don't know they have muscle weakness, but wo gir jate. And when you examine them, they can't get up from the kursi, So that's how they present. Can't keep the head steady when sitting. So the head tends to fall down because of weakness of the neck muscles. And many of these patients have pharyngeal weakness as well. Those who have neck weakness can have pharyngeal weakness. It's important to look at the single breath count in these patients because they may die suddenly. Remember, the CPKs can turn out to be normal in these patients over time. And there are various theories to that, which I won't go into. But the LDH is the last to go. So very often they have the muscle enzymes which are raised, and that is where and now you have the muscle specific antibodies also. I won't go into the details of those, but dermatomyositis is one disease whose investigational spectrum has changed maximum since I did my DM. I mean, there are so many antibodies now available, and almost all of us in those patients who can afford would order these to clinch the diagnosis and also prognosticate these patients. That is from the ACR. I think this won the award last to last year, and shows all the showings that you have. You show the heliotrope here. You can see the mechanics hands. You can see the Gottron's rash. On the elbow here again you can see the mechanics, and this is called the hitchhiker's feet. So you can see these various kinds of rashes in dermatomyositis. These are called anti-synthetase syndromes. Again, I won't go to the detail of individual ones because it will not be possible to cover all of those. Sarkar sir, we'll take the questions later on because some people
Yeah.
Okay, so
We'll question.
the fourth case is a 45-year-old lady. She started when she was 18 with lower limb purpura that disappeared on lying down. And this was a real life case that I saw. Recurrent parotitis over the last 6 years, admitted with hypokalemic palsy. And this is what the total protein and serum albumin in the blood showed. This was a real life patient who was admitted into an ICU, and I was called in. This was about 10 years back. And she was admitted with hypokalemic palsy. The hypokalemic palsy also was happening the second or third time. And nobody had paid attention to the fact that she had recurrent parotitis and that she had extreme dryness of mouth. Because people thought it's dry because she also had hypothyroidism because uska dryness hai. But if you look at the globulins, they are markedly raised, and this is what we call Sjogren's syndrome. You can see the purpuric rash here, which is hyper gamma globulinic purpura, which when the patient is in the gravitational position, it goes down, but when she lies down, it goes away. That's how they present. And she had started having hyper gamma globulinemia when she was 18 or 20, and now she presents with renal tubular acidosis as well, causing hypokalemic palsy. So Sjogren's syndrome can involve multiple areas. Remember, 60-70% of primary Sjogren's is just sicca. What I'm showing here is only 20-30% of cases who have the extra glandular manifestations. That is dry mouth. In extreme dry mouth, you can look at the cracks in the lips. This is extreme dry eye, another patient of Sjogren's. That is showing the parotid enlargement. And parotitis is something you have to ask them because they don't know that it is important. So we have to ask about that. And that was a patient of Sjogren's who went on to have cryoglobulonemic vasculitis, shown here in cold. And this patient eventually died actually. So things like parotitis, cryoglobulinemia, anti-Rho antibody, raised globulin in a patient of Sjogren's syndrome are markers of that these patients can go on into lymphomas, because Sjogren's is much more vulnerable to lymphomas than other diseases. And these are the markers, clinical markers that tell you. अगर किसी patient को recurrent parotitis हो रहा है, cryoglobulic vasculitis हो रहा है, उसका ESR बहुत high है, globulins बहुत high है, then that would be complement low है. These are patients I will suspect that they may go into a lymphoma, especially if you don't treat them early and aggressively. Coming to the mixed connective tissue disease, UCD conundrum. So mixed connective tissue disease is a definite diagnosis. You have to have puffy fingers or Raynaud's. And the important to know is that the puffy fingers shown here of MCDD, they remain puffy for years. They may have trigeminal neuralgia also. Some of these patients will eventually evolve into scleroderma. Uski skin tightening hone lagegi. Many people don't believe in MCDD, but it has to have anti-U1RMP positivity and exclusively anti-U1RMP positivity on the blot. UCTD is undifferentiated, again has criteria. You need 3 years of the patient not having differentiated into any connective tissue disease. Now it is very impractical, right? Who is going to wait for 3 years before diagnosing these patients? So if you have a Raynaud's with ANA positivity and nothing much to suggest anywhere, you label them as UCTD and you start looking and monitor them for evolving into myositis or scleroderma or those kind of things. Remember, overlap syndromes for postgraduates is when you have to fulfill the criteria of both these diseases. For example, polymyositis scleroderma overlaps, you have to fulfill both. Lupus Sjogren's, lupus myositis, lupus is rheumatoid arthritis and lupus. So you see various kinds of overlaps also. IPAF, I told in the beginning, is interstitial pneumonitis with autoimmune features. It used to be called lung dominant diseases. These are ILDs with autoantibody positivity, which means they can have rheumatoid factor, CCP, a host of antibodies, the myositis group. Anchors are not included in IPAF. So they are still not included, but the others, all of them, if you have an ILD with an anti-Rho positivity on the blot, then that becomes IPAF if the patient doesn't have anything else. And you treat it with immunosuppression. That's important to know. Coming to the last group of disorders, I think, is vasculitides. And important is, this is easily the most important slide for everyone, is that rather than going into whether it is ANCA associated or PAN or thing, I think what we need to do is to classify clinically kisko kaun sa hai vessel hai. So if you have purpura, vesicles, bulla, hematuria which suggests glomerulonephritis, hemoptysis which suggests alveolar hemorrhage, uveitis, episcleritis, then you think of a small vessel vasculitis, right? If it has nodules, non-healing ulcers which are slightly bigger, livedo reticularis, monoretus multiplex which is a wrist drop or a foot drop, gangrene of the digits, microaneurysm, then this becomes a medium vessel vasculitis. And if you have claudication, intermittent claudication, absent pulses, bruit, evidence of aortic dilatation, that becomes a large vessel vasculitis. And these are obviously the classification, the Chapel Hill. But for us, this is clinically the most important thing. So when you patient comes to you and you classify according to these. That is how it is shown here very well, that this is large vessels, that is a medium vessel renal vasculature going into the kidneys, and glomerulonephritis, this is small vessel vasculitis. So vasculitis case 1, 25-year-old lady, 6 months of left-sided upper backache, occasional giddiness, was told on first delivery 2 years back that one side pulse was difficult to get. ESR was high and ANA was mildly moderate positive, and CT angio shows here, you can see the subclavian stenosis. You can't even see the subclavian here, the left side. So that is Takayasu. You can have autoantibody positivity. The important thing is that young female coming with trapezial pain in the upper back and the back area, and the ESR is high, look for bruits and pulses. So and measure the pulse, blood pressure on both sides. These could be Takayasu. Sometimes we miss them. This is giant cell arteritis, not frequently seen in our country. We have just about a couple of cases, each of us. They present with headaches, and importantly, I have seen large vessel or giant cell arteritis presenting as PU, and these are picked up on PET scans by the ID specialist sent to me. So you do a PET scan for fevers and high ESRs and CRPs, and you have these on the PET scan vessels, axillary and subclavian other vessels which are inflamed, and then you call them giant cell arteritis. Otherwise, I haven't really seen very many cases of giant cell arteritis, and this is the biopsy to show that. The case 2 is a 52-year-old gentleman, presents with fever for 6 months, high grade, chills, has significant weight loss, has joint pains, inflammatory polyarthritis. You can see the rash here on both sides. This is paniculitis on both sides, tender raised rash. And last 1 month has also developed a foot drop on the left side. So this is what we call as classic polyarthritis nodosa, because you have medium vessel involvement, evidence of all that. They have scleritis, necrotizing sometimes, and these are renal aneurysms to show. This is from New England Journal of Medicine, I think, and just to show that these are these beaded, you do look at these beads, look at this beaded appearance sometimes, or these aneurysms. Fibromuscular dysplasia is a differential of this, where you show the string and bead, but this is PAN, polyarteritis nodosa, classical medium vessel vasculitis. The third case is a 30-year-old gentleman who presents with history of 1.5 months illness, fever and joint pain, small and large, rashes, blisters over legs and feet, and oral ulcers for the last. This is the kind of ulcer this patient has had. Look at these huge ulcers. Cough initially dry, then with sputum, and for 2 days, hemoptysis, dyspnea on exertion now, and the X-ray shows cavitary lung disease. So this is very likely you have pulmonary involvement, you have a huge punctured oral ulcer, some systemic symptoms, and these are the kind of blisters these patients have because of ischemia and vasculitis, small vessel vasculitis of the. This is she has put some medicine over it, that's why it is blue. It is not actually blue. This is because of the medicine ointment. But these are the, you can see these blisters here. Past history of recurrent nasal crusting, sinus problems, ENT visits, very importantly, operated for sinusitis O2. Now, they don't tell you this until you ask them because they don't relate them to the present problems. So you have to know about Wegener's and ask them about GPA, these, and then they tell you. On examination, non-blanchable lesions over both legs, red eyes, and inflamed nasal turbinates. There are also active urinary sediments and a creatinine which is raised, and an ANCA by ELISA which shows PR3 proteinase 3. We all know that we know what are ANCAs by ELISAs. So this is a classical case of a granulomatous with polyangiitis, what we call Wegener's granulomatosis. The differentiation here are infections and some lymphomas. That is a saddle nose deformity seen in Wegener's. These is a cavitary disease seen in Wegener's X-ray, and that is diffuse alveolar hemorrhage with some organized pneumonia also seen again in GPA. You see this kind of a picture also in MPA. Microscopic pan present with just diffuse alveolar hemorrhage of the lungs and anemia. Sometimes these patients don't tell you that they have hemoptysis. उनका hemoglobin कराओगे तो 6 आएगा, and you do a CT scan and it will show bilateral infiltrates. That is how MPA most often presents, and most of it goes to the renal because they come with raised creatinine simply straight away with glomerulonephritis. This I purposely put here was a case of staph endocarditis who was strongly C-ANCA positive, and she had brain lesions which were reported as vasculitis and a C-ANCA positive, and I had called it Wegener's with fevers. This patient did not respond to, initially responded, but then did not respond. Eventually it turned out to be a staph endocarditis and had to undergo surgery and replacement. Endocarditis bacterial can have C-ANCA positive in about 30% of cases. So that's the message here. We got it published in one of the journals. This is small vessel vasculitis, just to complete the vasculitis spectrum. This is HSP, most common. These are scrotal ulcers seen in Behçet's syndrome. Remember, Behçet's can have all vessel involvement, small, medium, large, any kind of vessel involvement. This is episcleritis, usually doesn't need any treatment. And this is a related, a mimic, again, I think was from New England, one of my patients reported as as aortitis. This is IgG4, which can have, it is difficult to differentiate just based on CT, and you need a biopsy to show IgG4 related cells, which should be more than 40% in most of the tissues from the plasma cells, and a characteristic histopathology. IgG4 related syndrome can have other manifestations also. I won't be covering that in the present talk. So coming to the last slide, what are my key takeaways? And these key takeaways are going to be more for postgraduates and for practitioners, because I'm sure the practitioners themselves have wisdoms to share. And I'm not summarizing my slides because that is something that all of you know. And these are things that I have learned over time, which I'll try and share. So the first is, consider epidemiology and commonality when thinking of a diagnosis as per the demography of the patient. So when a young male, for example, walks into your cabin and somebody has told you that he has an arthritis, कि उसको inflammatory pains hai, my mind would already start going towards a spondyloarthritis unless and otherwise proved. And then the patient sits and tells कि मुझे spine pain है, मुझे backache है, मुझे buttock pain था, sciatica था, lower limb था, and that validates my diagnosis. Similarly, if it's a young female who walks in with you can't see the joints, but you can see the palatal ulcer and some rashes here and there, then you start thinking of lupus. And if it's a female with symmetrical polyarthritis, you start thinking of rheumatoid arthritis. So the epidemiology and commonality of the disease also has to be under consideration before giving importance to an individual investigation. So suppose there is a symmetrical polyarthritis patient with an ANA 1+ and nothing else to suggest connective tissue disease. I would not even look for a CTT in that patient. I would keep that as rheumatoid arthritis. Even if the RF is negative, in this patient, I would call it seronegative arthritis because that is far more common than than just 1 plus ANA and nothing else to suggest a connective tissue disease. The second is try to go back from where the patient says it started. Not infrequently, there have been prior episodes or something relevant to the present problem. And this is something I've found most commonly with all due respect to orthopedics, that they have one knee joint involvement in a 25, 30-year-old male. They open it up, arthroscopy and all of that. And then when they send to you after everything, the biopsy shows inflammation. You ask the patient and he says कि सब जब मैं 8-10 साल का था तब भी मुझे इसी नी में एक बार पहले हुआ था, ऐसे 2-3 महीने हुआ था, चला गया, फिर उसके बाद एक और बार एक्चुअली 14 साल की उम्र में हुआ. So I think it's very important to, when you ask the patient, he will simply say current problem कि अभी हुआ है, because they don't know. So you have to go back and ask them कि पहले हुआ है कि नहीं, and that saves a lot of effort for you also, because you stop thinking of infection if it is happening recurrent. By and large, unless it's an immunodeficiency syndrome, you think of an inflammatory illness. So that's where it helps. The third is try to localize exactly if it's a joint periarthritis or tenosynovitis, because that sometimes gives a clue. Tenosynovitis, for example, chikungunya is more of tenosynovitis, more of carpal tunnel than rheumatoid arthritis. Sometimes these patients tell you joint pain hai, lekin actually joint hota hi nahi hai. They are just hypermobile syndromes and there is no inflammation in joint. So try to localize. Ask the patient कि नहीं तुम बताओ कहाँ होता है exactly मुझे, उस टाइम पे कहाँ हुआ था. Just give them that much of time to listen to them. Look elsewhere for a clue. Example, lungs, skin, kidneys. That's very important because that tells you if it's a systemic disease like lupus or vasculitis rather than just a rheumatoid arthritis. And you have to really ask them for that because they don't know, they don't relate it. आंख में हुआ तो उनको पता नहीं है कि उसका relation इसके साथ है. You have to do that. So you have to ask them about all these things. For the PGs, very important. Think of the differential and rule out one by one, not a yes or no. And there was a very interesting perspective in New England Journal of Medicine about 6 years back where they actually said this. What we do in practice, and I must confess, is a yes-no thing. हम लोग बहाना लेते हैं कि हमारे पास टाइम नहीं है. So we have a list of things. बाल झड़ते हैं, मुंह में छाले पड़ते हैं, लाल होता है, अरे relevant ही नहीं है. So think of a differential when you are taking the history. Rule that out one by one. That is the correct way of learning clinical medicine, rather a simple yes or no. Don't forget asking about the functional status of the patient, something we miss in post-graduation definitely, and something we've learned after post-graduation. Is that ask about the functioning of the patient, because that tells you कि सही में कितना problem है उसको and how much of his daily function has been hampered. What all doctors did, you see in the last couple of years or back then, and looking at the doctor's notes has helped me list the issues in technical terms items. Example, cutis laxa. So what all doctors did you see in the last couple of years? As I said, vaginals I picked up by asking कि आप ENT स्पेशलिस्ट के पास कितने बार गए, तो बोलेगा सर पिछले 2 साल में 10 बार जाया है, कम से कम 6 बार जाया है, ये रिकरेंट होता ही रहता है. So and the second thing I found is that in our country when they go to a doctor it is significant. Many women will just keep complaining about aches and pains. लेकिन आप सही में डॉक्टर के पास गए थे, then it becomes significant. And looking at those doctors' notes, and this is one case which I'll not go into the detail, but I was in a very confused case of 40-year-old who looked like a 70-year-old. कि उसका स्किन इतना इलास्टिक था, and I tried to Google क्या है midline में डाल के कुछ मिला नहीं. Then I saw doctor's note, dermatologist had written cutis laxa, something I didn't even know about. Then I typed cutis laxa, and I actually could make a diagnosis. So it's important to look at the doctor's note sometimes. List of the organ systems involved. List the organ systems which are involved as a part of diagnosis. Rheumatoid arthritis, monoitis multiplex, ILD, like that, or lupus, nephritis, neuropathy, whatever system which are involved. Thinking of the ongoing mechanism. Think of could it be ischemia, infection, inflammation? There are clues from the above. As I said, if it is recurrent, it is more likely to be inflammatory. If it is bilateral, symmetrical, it is more likely to be inflammatory. This is not always the rule, but by and large. Infection is usually unilateral, it crosses tissue planes and happens just once. There is some evidence of some kind of immunodeficiency in that patient in terms of receiving steroids or immunosuppression or diabetic or something. So think of the mechanism also, ongoing mechanism which is in that patient. And that is how you zero into a differential. The examination will add little. Remember, it is always the history which is most important 80% of the times to this, and then look at the investigations for a final diagnosis and not the other way around. What I've seen, and I think this goes for every generation. Every generation says कि यार ये younger generation ठीक से देखती नहीं. I think that was true for our teachers also. But I think the basics remain the same. Professor Sarkar or Professor Ganguly or Professor Banerjee would always go through the history and then look at investigation. It remains the same over all these decades. because investigation will only add confusion. There is only an occasional outlier. Pattern recognition, then investigations, not the other way around. Except for an occasional anti-CCP or an ANCA outlier. Only occasionally you will find an investigation which is an outlier in a case which clinches the diagnosis. Otherwise, by and large, this pattern has to be followed. I don't know, 10, 20 years from now, you may be looking at transcriptomics and genomics of the patient's blood and giving a diagnosis. But as of now, this I think still remains the truth, the clinical truth for all of us. I'll just end by quoting what John Kush is one of the leading rheumatologists in Texas, and he works on Still's disease. And he very nicely said for rheumatologists that for all us fellow rheumatologists that you are in the field of pattern recognition, rheumatology especially. Kush argued, it's a visual art. You can have all the numbers you want. You can have the DAS28, you can have ESR, CRPs, ANCAs, transcriptomics. But you make the most of your decisions based on pattern recognition, which is not rooted in numbers or metrics. And that's why you're successful at what you do. So to be a successful clinician, I think it's very important that you lend your ears to the patient, listen to them, ask them specifically, give them time, and make a clinical diagnosis before the investigations really get you confused. Thank you, ladies and gentlemen. I'll be ready for any questions.
Thank you. That was a nice discourse with the pattern recognition and the spectrum of this multi-system disease actually. Now, going to the questions. There are some questions in the chat box. Do you think both CCP and RF negative reports should be called seronegative? Because quite often we say seronegative. And there is a misnomer also from many institutions, seronegative spondyloarthritis.
So seronegative, do you think both CCP and RF negative reports should be called for seronegative? I don't really know, but yes, I would do both before calling it seronegative, because sometimes patients are strongly CCP positive and RF negative. I would treat them as seropositive rheumatoid. And becomes important for rituximab, because if you want to give rituximab, it has to be either RF or CCP positive. So yes, I would require both to call them seronegative.
Another question is rheumatoid lung and methotrexate. Should we think JAK2 inhibitor in those cases, ILD with rheumatoid arthritis?
So I think that has been well discussed, especially Professor Malviya has been advocating a lot that except for methotrexate, hypersensitive pneumonitis in an occasional case where you get eosinophilia, and because of the hypersensitivity, methotrexate doesn't really cause interstitial lung disease, and so we can use that also in patients. I'm not aware of any evidence of JAK2 inhibitors in ILD. I don't think the evidence is still there, so I would not use it per se for the ILD. But if there is mild ILD and more of joints, yes, I would use JAK inhibitors if need be in these patients, and not much worry about the interstitial lung disease.
Relationship between antibody and CTD pattern.
So again, that's an interesting question. There are some associations. For example, the Rho antibody, as you know, is associated in lupus with congenital heart block, with cytopenias, hematological involvement with subacute cutaneous lupus. There are also associations of anti-Jo with anti-Jo syndrome is a part of anti-synthetase syndrome again. In myositis, you have MDA, for example, with very severe ILD. So there are these definite associations, but not always. So some of them are quite specific, but not all of them, I would say.
Role of indications for muscle biopsy and MRI in polymyositis and dermatomyositis.
So with the advent of myositis-specific antibodies, I think the need for biopsy has is almost not there now. But yes, that is still remains the gold standard according to me. And when you do a biopsy, when you want to do a biopsy, you might do an MRI to localize where to do the biopsy from. And some people also use MRI to know between inflammation and atrophy, because problem तब होता है जब myositis थोड़ा late आता है and you don't know if there is ongoing activity or there is fibrosis. That is the time we do MRIs to look at if there is some activity in these patients. But MSAs have replaced biopsies mostly now.
Whether dry eyes and mouth a must for Sjogren?
Well, for primary Sjogren's, it still remains if you look at the criteria which came out, and I today that you don't actually look at criteria, but if you want to diagnose primary Sjogren's, yes, you require SICA, but I'm sure you have seen patients who don't have SICA, but they have RTA and they have anti-Rho, which is strongly positive, or there is purpura and there is strong anti-Rho positivity. I call them form first Sjogren's, which means to look for evolution into Sjogren's, and I start treating them as Sjogren's syndrome.
Onset's disease, what is the recent status?
I think Aman Sharma just came out with that criteria about 2 years back. Aman and Sharma and Pinto criteria for Ponsets. You can find it in Google, and the status overall remains the same. You suspect that it's a reactive arthritis to the tuberculous protein. So in patients who have tuberculosis or are on anti-tuberculous therapy, you find this polyarthritis, sometimes more often oligoarthritis of the ankles and the knees. And they go away with, while you're continuing treatment, they usually go away. It's not much of a problem as far as the treatment is concerned or the prognosis is concerned. But we do believe that there is Ponsets, yes.
One of our sports directors to give a vote of thanks and his comments.
Thank you, Professor Amol Banerjee. This is one of the finest lecture and practical lecture I've had in my life. So thanks to Sapan again.
Thank you, sir.
Also thanks to Professor R.N. Sarkar for conducting the session, and also all the audience who have definitely benefited from this lecture. Now I'm handing over to Professor Amol Banerjee for his final announcement.
Thank you, Shotto, Rotin, and Sapan. Sapan, you have delivered a very excellent, I would rather say excellent master class.
Yeah.
Thank you, sir.
Yeah.
I think
Excellent.
it would be good teaching for the PGs and also the practicing physicians.
Thank you, sir.
Anyway, I expect your class, your teaching, we will have in future also.
Thank you, sir. Thank you very much.
With these words, I adjourn this session. Next month, October, is a month of festival.